Welcome. Welcome to this forum on integrated care and housing for homeless people in Los Angeles. I am so appreciative of the time that you are taking today to come together and discuss and strategize about this very important topic for us in Los Angeles. Let me also thank Scott and Obaida Watt for underwriting this event. Scott and Obaida are longtime supporters at the school. They are members of our school's Board of Counselors, and they share our deep concern for improving the lives of people who've been affected by homelessness. We're focusing today on issues within our home, Los Angeles. This is a city that makes its citizens proud in so many ways. LA is one of the most ethnically and racially diverse cities in the United States. Did you know that there are 200 different languages spoken within the boundaries of the city limits? That is fantastic. Our city is also the largest manufacturing center in the western United States. We're home to some of the best colleges and universities, some of the best health care in the nation. So this is a region with abundant resources, much to be proud of. Yet, since the mid-1980s, Los Angeles has also had the distinction of being the homeless capital of the United States. There are more people homeless in LA than in any other city in our nation. But even in the face of that dire situation, there is, again, much to be proud of. There are so many people like you and organizations and agencies like yours that are dedicated to serving homeless people and to ending homelessness. We are so rich with human resources in Los Angeles, so rich with human potential. And I know this personally and professionally, having spent almost 20 years as a community-based researcher in Los Angeles, in collaboration with providers across the city and the county, and with women, men, and youth who are experiencing homelessness. In today's forum, we're focusing on integrated care for people in temporary and permanent housing. Integrated care broadly refers to the coordinated, proactive delivery of comprehensive health care that is tailored to an individual's needs. No matter where people are living, they should be able to access primary care, behavioral health care, and services including HIV prevention programs, vocational training, other assistance as needed by the individual. There have been significant accomplishments in achieving services integration, but also many challenges. And these exist on multiple levels: individual, social, systems, policy. Our goal today is to enhance our collective understanding of integrated care for homeless persons in Los Angeles, and we want to identify key challenges and strategies for advancing and sustaining integrated care in our city. Now, please allow me to introduce the Dean of the School of Social Work, Marilyn Flynn. Without her vision and her support for research and critical dialogue on topics like these, this day would not be possible. Marilyn Flynn has served as our dean since 1997, and during that time, she has been committed to building partnerships and supporting communities of Los Angeles.
So many of you are familiar with the School of Social Work, I think, probably through our internship placements, our research, or other community leadership roles that we've played. The school itself is 100 years old, approximately, depending when you start counting. Every year I've been here, I've told people it's 100 years old, so it's kind of a moving target. We have enrollment now of over 2,000 students in our MSW program. Half are here in Los Angeles, Southern California region, and half are in our web-based virtual academic center in 38 states across the country. Right now in Los Angeles, we're working with over 1,000 private, nonprofit, and public organizations and for-profit groups, as well as our other university colleagues at Cal State and, yes, UCLA. We have one of the most accomplished groups of researchers of any school of social work in the country, And we have particularly distinguished work in depression, schizophrenia, homelessness, child maltreatment, aging, health disparities, and addictions. However, it's one thing to carry out research. It's another thing to use it productively. The concept and the promise of integrated care gives us a sense of possibility about finding those in a more effective way and organizing our care around them in a more effective way, of finding solutions and bringing answers to light. Whether implementing cutting-edge improvements or ensuring the delivery of fundamental services, Councilwoman Jan Perry is making a positive change in the lives of her constituents. She's now in her third term in office as Councilwoman of the 9th District, and she represents some of the most diverse and vibrant communities in Los Angeles, including Bunker Hill, Little Tokyo, and South Los Angeles. In 2008, she authored city legislation to end the practice of dumping homeless individuals in Skid Row hospitals by hospitals and other institutions.
Good morning, everybody. It's a pleasure to just share a few thoughts with you this morning about my experiences going back to 2001 when I was first elected, and my district included, they're back, Central City East or Skid Row. When I look back at that time, the homeless count for Los Angeles County at the time was 78,000 people. These were people who were defined as those without a permanent home. And the number was tossed around a lot by people in political places like it meant nothing. And there were no alarm bells ringing. There were no late night news breaking stories about our region being the homeless capital of the country. And no one, with the exception of a very few good people, and one of them is here in the room, and I have to call her out, Ruth Schwartz. Okay. Ruth is an angel. She just left her wings at home today. But Ruth Schwartz has been a mentor and a guide, and she woke us all up. Now, at the time, we had a new mayor. His name was Jim Hahn, and many members of the city council were just newly elected, including myself. Skid Row was seen to be the answer to everybody's homeless problem in the region. So if you're homeless, you just go to Skid Row, and you live on the street, or maybe you'll get into a cot somewhere or get some help. That brought thousands of people from jails and other jurisdictions throughout Los Angeles County, hospitals, mental institutions. People just got dumped in downtown Los Angeles and Skid Row. And there was no plan in place for managing this issue, no coordination or effective housing effort. Again, not a lot of concern. The politics of the problem had been to defer to the nonprofits and the faith-based agencies just to deal with the problem. On their part, the agencies, the missions, they were drowning. They were drowning in clients and lack of funding, and so this is where I started. I spent time, and my chief of staff spent time meeting, talking, trying to figure out a framework to attack this issue. Lots of people from homeless care providers from both faith-based and nonprofit communities to hear what they had to say and to have them tell us what they felt they needed. We examined the continuum of care and found that there was no continuum. We were trying to find a starting point and to try to work towards that goal of ending homelessness. Now, a new city council, and it was trying new things. There were members like myself who knew that the city had to do far more to develop affordable housing and examine how homeless services were provided. So I knew that we had to work with LA County in a more effective way to get the resources that we needed for homeless health and mental health care. So I wanted to extend the cold, wet weather emergency shelter program to a year-round program. And it seemed odd to me that we in the city only used federal money to shelter the homeless from mid-December to mid-March, So I felt that this had to change. So I did go to the Board of Supervisors and ask them to join the city in an effort to shelter homeless year-round and to add services. Now, I was advised at that time, and that was a long time ago, now, to hold a fundraiser. This is a true story, and so how do I say this? That was just a really stupid thing to say. So it was 2002, though, so hopefully we all got a lot better. Mayor Hahn and the council members began working to put together something called an affordable housing trust fund as a means of stimulating affordable housing production. So I worked to extend the emergency shelter program year-round. Mayor Hahn agreed to fund it, and then slowly we began to add services: case management, health care, mental health care services, and the program grew. So by 2005, the Housing Trust Fund was implemented, and there was a dual program established in the Fund for Affordable Housing and Permanent Supportive Housing. So an even more specific, more dedicated stream of funding. This fund is a high leverage fund that combines local resources with federal resources, state resources, rental subsidies like Section 8 and Shelter Plus Care to assist for and to provide nonprofit affordable housing developers the opportunity to compete for loans and grants. Now, the Housing Trust Fund at the city has been an enormous success. We have built thousands of units of affordable housing and permanent supportive housing that includes services on site for people who are homeless. Not every homeless person needs permanent supportive housing. It's really intended for people who need on-site supportive services. Now in Los Angeles, about 35% of the homeless population is chronically homeless. These are people who have experienced episodes of homelessness with frequency and chronically. That's our greatest challenge. Chronically homeless people in our city and county are homeless now on the average for 8 years. 20 years ago, that number was 6 months. The longer a person with mental illness or chronic physical illness or substance abuse issues is homeless, the more it costs and the harder it will be to house them. So we had to appeal to housing providers to take the most vulnerable and chronically homeless individuals to work on housing them. It's very, very hard work and extremely labor intensive. But in my view, it is what is needed for us to truly impact the issue of chronic homelessness in our city and in the region. So in order for us to get our arms around the problem, I knew we had to push hard on the county for services because that's where the money flows from the federal government. The homeless population was not high on their list of priorities. The county tends to favor boutique homeless programs like Project 50. Project 50 proved to them that it's really hard to successfully house chronically homeless individuals, but we already knew that. So I'm not in for that Project 50. I wanted to be able to leverage people we already had in emergency or temporary housing and have them become housing ready and move them through Project 50, but we could not strike an agreement with the county. But I am in for a project in the thousands because that's what we need. Thousands of housing units for very low-income people that are at risk of becoming homeless, as well as for the chronically homeless. We already know single head of household families are at risk of becoming homeless. Single mothers with poor education are at great risk. We know that older adults are now at greater risk of homelessness. We know that 47% of the homeless population is African American men. We also know that cutbacks in federal funding will place more people at risk of becoming homeless. Funding formulas are a challenge for us, as well as the city of Los Angeles. And the cities receive 50% of the homeless population, but we do not receive 50% of the resources to be able to take care of this population. Now, LA County continues to mount new initiatives on homelessness, and I'm hopeful now, but a little bit skeptical, but I'm going to try to believe that if Los Angeles County were to adopt new policies like increasing general relief, a major cause of homelessness from $221 a month, it would be a beginning. That number has not changed in over 20 years. I have asked for years that county departments be represented on the Los Angeles Homeless Services Authority Commission so that they can guide resources into homeless programs. It has not happened yet. But I am a pragmatic person, and I know that government can do better and get more out of their investment. The city of Los Angeles cannot bear this burden alone, and Los Angeles County is far too big, and it requires that other cities in the county, 83 of them, should do the same. It would be much better for families and individuals to receive homeless prevention services where they live. It is no longer legal for institutions to transport people to Skid Row against their will, and as was mentioned, I authored that legislation, and it's working. There has been a change at the county now with a new medical director. His name is Dr. Katz, and I feel that he already understands the nature of these issues. He worked in San Francisco, which was one city, one county. A far better arrangement for the allocation of resources and policy and program planning. And I told him that medical services at the shelter will dramatically reduce paramedic calls and hospital visits, and it makes sense. For my part, I have never rejected a homeless housing project for my council district. Thousands of units have been built in the past 10 years. Many of these projects have won awards for their design and the way that they help their clients recover. Permanent supportive housing does work. However, again, I want to stress, not every homeless person needs permanent supportive housing. Some people who are homeless get on their feet directly out of a shelter. And for some, it is a matter of finding a job and saving money and being able to move forward. And for some, like the two 83-year-old twin sisters who became homeless last winter, and I met them at the homeless shelter in my district, the best placement was in an extended care facility because of their age. Now, this is why I think that year-round shelter is so important. A well-run year-round shelter can provide a portal for services and establish priorities for homeless clients. We work to fund housing location specialists at the shelter to place clients in the best possible living situation with the long-range goal of successfully maintaining them in housing. It works with about 80% of the clients maintained in housing long-term. And it's a wonderful outcome for people who are chronically homeless individuals. We've built specialized housing for populations. One project at the historic street, the 28th Street YMCA, just off of Central Avenue, will house transitional age youth with support services on site for both the community and clients. The Downtown Women's Center at 5th and San Pedro serves homeless women with case management and health care services, and it provides respite care and permanent supportive housing for women with mental illness. It's their new home, and it's in the Renaissance building that was once owned by the city, and I worked to convey it to the Downtown Women's Center for $1 a year. Then the agency itself raised $30 million to complete the project. And if you have time, I urge you to go see it. In fact, one of the many housing projects in downtown, this is one of the most beautiful. The new Carver, the Abbey, the Charles Cobb Apartments, and I have a list of projects that goes on and on and on. And I would build more if we had more resources. We're using every dollar available to address this need for housing because I think we know what works and we know what doesn't work. So ignoring this or any problem, as long as our city and our county did, brought us to this day, and now we're digging our way out. Every new project brings the promise of a future for many people who have been forgotten or thrown away. Now, I think that's part of a social contract, and I think we're obligated to help people who need our help the most. The face of homelessness is not what most people think. It's too easy to dismiss the problem by characterizing the lives of people who are homeless in simple terms like drug addict, substance abuser, no good, or, all those things. And, a lot of people do suffer from substance abuse. But we can't forget that many people are simply those who are in unfortunate situations and they don't have a support system, or they have aged out of foster care, or they are poorly educated, or have suffered from a reversal of fortune. Now, it's always interesting to me to ask other elected officials, so what projects have you supported in your area, your district? And I always say to people, you watch how people vote, and that says volumes about their level of commitment to solving this issue of homelessness, and whether they voted to fund or build or support homeless projects in their own districts. Our city is about to undergo the budget process. Now, last year, the money for the year-round shelter was taken out of the budget by the mayor, and I had to work very hard to restore it, and I have no doubt that I will have the same battle again this year. It is ongoing. The problems of the homeless are many, and I hope that some of you will help me take this cause up. Now, as I've said, things have gotten better. We are receiving more rental subsidies for veterans, and we're building housing, and LA County is beginning to work to place homeless, mentally ill people into housing that we have built, as well as placing them in scattered site housing. Of all the work I've done, this has been the most meaningful because there is no political advantage for doing this work. This is not a demographic from which I get a lot of votes, I don't raise a lot of money, and most of the time they don't even know who I am. But it's fulfilling to see people move into housing and get services and get their health back, get their social skills back, and to be able to get back on their feet and to be able to live meaningful lives. But I have to tell you, if homelessness did become something that had some political advantage, I think it would be the centerfold of many people's political careers. I'm happy to say that right now, on top of everything else, I've got 5 new homeless projects in production right now. They're called the Star, the Genesis, Gateways, the rehabilitation of the Pershing Hotel, and of course the Roslyn hotels. I never forget stories of people that I meet. I may have said this to some of you before. We go on our homeless walks, and I remember this several years ago, and it's one of those stories where you think, wow, if I had only stayed there 5 more minutes and maybe looked right instead of left. We talked to a lady, and we were out with folks from LASA and the police and other providers. Met a lady, talked to her for a while, and said to her, it's not safe out here for a woman. You know, you need to come in. There are beds tonight. We can get you a bed right now. Would you please come in? She said, no, no, no. And all of you know, I'm sure you can't force people to take services against their will. So she walked off, and it was twilight. And 2 days later, I saw her face in the LA Times because she'd been murdered about an hour after we left her, stomped to death by someone out on the street. I never forget those stories, and I think about her every day. I think about a 90-year-old woman who stayed at New Image Emergency Shelter and insisted on staying there because her drug-addicted son slept outside the shelter on the street in the car every night because he wanted to be near her. Now, she would not move into housing until he died, and he did. And then once he died, she could move on. And I told you about the 83-year-old twin sisters. So many people who've lost their jobs or their employment, their apartment, living in their car. We've had an entire generation of people who have no financial plan, and they may retire or be forced to retire or have to rely on their children to sustain a living situation, and that's happening right in front of us. So many young adults living with their parents for the same reason, more now than ever before. And if they did not have the support of family or friends, they might be homeless. That's quite likely. So we can continue to count the homeless by the thousands here, but I think all of us can be part of the solution. And you can ask anyone who's running for office what their position is on homelessness, and will they support affordable housing projects in the districts or the areas that they represent. We have not stopped, and again, I couldn't have done this without the help of people like Ruth Schwartz, Los Angeles Homeless Services Authority, and the now deceased Redevelopment Agency, the Corporation for Supportive Housing, Shelter Partnership, the Housing Trust Fund, the general fund of the city of Los Angeles, and the matching state and federal housing programs that have helped us to build all of this housing. So, you know, it takes a bulldozer to get all this done. But you know what? This is an 8-ulcer job on a 4-ulcer pay from our former president, Harry Truman, and I think this applies. But I admire people with the stamina to hang in there and to do the work, to do the planning, the development, and implement the policies that help people recover their lives. That's attractive work. It's not easy work. What you'll find as often as I do, it's the simplest ideas that often make the most sense and are easy to implement. Those are the ones that are most often ignored for the, very fancy, high-cost programs where the results can be achieved for less money. So it takes more than one person. It takes more than me. It takes all of us pushing hard, making a demand that the issue of homelessness remain front and center, because it is a worthy cause and one that should be supported by all of us. Thank you very much.
We have 5 distinguished speakers. Elizabeth Boyce, or Libby Boyce, who is the Homeless Services Coordinator for the Los Angeles County Chief Executive Office. Chris Coe, Program Officer, Housing Stability, United Way of Greater Los Angeles. Peter Lynn, the Director of the Section 8 Department of the Housing Authority of the City of Los Angeles. Marvin Southard, Director of the Los Angeles County Department of Mental Health. And John Viernes, Director, Substance Abuse Prevention and Control, Los Angeles County Department of Public Health. They will each be speaking for about 8 to 9 minutes, back to back, and then we'll open this up for discussion with the audience, for questions. And please remember to use the microphone. Thank you. Whomever would like to start first, feel free. We could go in order of the agenda. Elizabeth, if you'd like to go first.
It's working. Good morning, everybody. I'm Libby Boyce. I'm the Homeless Services Coordinator for LA County. I'm also a licensed clinical social worker for the social workers in the room. The county, I work for the Chief Executive Office. We oversee the board offices and the department's homeless services and activities. And the county has been providing services to the homeless population as long as they've existed. We also have a community development commission that provides millions of dollars of capital funding for housing development. But I want to say that there are a couple of turning points in the mid-2000s that really sort of changed our approach and how we address homelessness. One is the Mental Health Services Act, which Dr. Southard will speak of. And the other is a lot of the media attention on the Skid Row issue in the mid-2000s, 2005, really kind of brought a renewed interest in the homeless population in LA County. And because of that, the departments were asked to come together and talk about our discharge policies and our systems and how we approach homelessness. The Service Integration Branch facilitated that process, and what came from that was the Homeless Prevention Initiative, which was a $120 million initiative back in 2006, which allowed departments and communities to develop programs to address their homeless populations and to develop service delivery systems for communities that really work. And there is some ongoing Homeless Prevention Initiative, which is available every year to the tune of about $15 million. And I want to talk a little bit about what we've sort of learned from the Homeless Prevention Initiative. What we learned is that housing with the right level of integrated supportive services is the solution and what will end homelessness. And that's no easy task, more than a notion. But we had many projects, pilot projects, that we conducted that really helped us figure out how to do this. And one of those projects is Project 50, which now has been replicated to the tune of about Project 600 or Project 700. But what, that really taught us was, permanent supportive housing was not a new concept, obviously, but it was the first time the county was very, very involved. It was the first time our department, which is still, Department of Mental Health still runs all of the Project 50 expansions. It was the first time we really focused on the sickest individuals, the most vulnerable individuals living on the streets of Skid Row, which is very different than, homeless families or transition age youth or, folks that have had one episode of homelessness. And what we learned is that the integrated team is totally critical to the success. You've got to identify who you want to house. You've got to work with them and engage them to be interested in housing, to accept housing without strings attached. And you've got to wrap services around them to keep them, retain them in housing, and to meet their needs. And it has to be the integrated team. And when I say integrated team, I really mean health, mental health, substance abuse, case management. Those are sort of the four really main components to a supportive services team. You have to have a very flexible approach and non-traditional approach. You can't, come in the lab coat and expect them to come to your clinic and so on. We had to approach it totally differently. And that's really, really what we learned. And we also learned that we can't work without one another. We have 24 partner agencies in Project 50, and we have so many more that we're now working with. And, really because we have been working in such silos and we have such, funding requirements in our large systems, it's something that needs constant attention, is making that kind of a model work. And it's very, very challenging. It also requires political will and very good leadership. But the outcomes show that it works, both from a financial perspective and from a human, the humane place, obviously. And it's the right thing to do. And I just want to say, being kind of like a visual person, what we know that the anchors to end homelessness is housing, rental subsidies, supportive services, and benefits. Those are the components. Then how you apply that, depending on the population, the homeless population you're trying to serve, how you make those wheels come into motion, how you put all those pieces together is the trick. And so it has taken a lot of pilot projects. It has taken a lot of, experience and good experiences, bad experience, and refining. And so what we're really trying to do is to continue with those lessons learned. And we're doing that through service partnerships. We've gone out to many, many different communities and helped health providers, substance abuse providers, mental health providers to come together and think of how they can develop a service delivery system in their community that can align with housing resources. Housing developers don't want to develop housing for special needs populations unless there's services, and they're right, because you want to keep people retained in housing. And so, we've gone out and taught communities how to do this without additional funding sources, with existing resources, which has been very important in our current economic crisis. We have many different demonstration projects going on. We have a TAY demonstration project, which is trying to work with transition age youth in a permanent supportive housing model, which hasn't really been implemented much in the nation, believe it or not. There's a real focus sort of on transitional housing for that population, so we are doing a demonstration project in San Fernando Valley and San Gabriel Valley for transition age youth. We have rapid rehousing programs, a lot of what we've learned through the HPRP, which is homeless prevention, rapid rehousing. And that's amazing. It's basically trying to divert people from shelters. We really don't want people to have to go to shelter. I mean, that's ideal. We want them to get rehoused. So we are really trying to focus our efforts on finding ways to implement rapid rehousing. Department of Health Services is doing a lot of housing projects and aligning our resources with the City Housing Authority, with the City Housing Department, with the County Housing Department. We're aligning our resources. We're layering and leveraging our resources to have housing services, rental subsidies, and to make sure folks get benefits. We have a funding collaborative in which the United Way began a funding collaborative with lots of public-private partners And we work with a lot of folks right here on the panel. And we have, just as an example, we have 500 Section 8s, some, most from the Housing Authority of the City of LA, some from the county. And we are expanding what Department of Mental Health does, what Department of Health Services does, so that their clients who are homeless can have access to housing, and then they'll have the wraparound services. So we're layering, as I mentioned, our funding. And the private sector is involved with the Funders Collaborative, which is really great because all of us have things that we can fund and things that we can't. Revenue sources and you know, areas that we don't have revenue sources. For example, move-in assistance, you know, 24-hour crisis team, you know, interim housing, some of those things that are very hard for us, we don't have revenue sources for, so the private is sort of layering their ability and what they can bring to the table. So we're not out doing different things. There's also an LA County Interagency Council on Homelessness, which is an internal, interdepartmental forum for us to really begin how to scale up our efforts, take what we've learned and blow it out. And so that's sort of where we're at right now. So there's a lot going on. There's a lot of collaboration going on, really, really good things. I think it's an amazing time to be doing this work, and you know, I'm really optimistic about the future.
I want to start by sharing a story. I was in a tenant focus group, so people who had been formerly chronically homeless, who are now in permanent supportive housing. At many of the sites that your agencies represent, we're just hearing their stories about what it took, what success meant for them. And something that really stood out at me was that for every success story that was shared, they mentioned about 4 to 5 different agencies in their story. So even if they were at Housing Works or at a site by Path, their story included visits to a DMH clinic or their meeting with a case manager at another agencies. And they were very clear on how much each of those things were turning points. So from that story, and I think in our day-to-day lives with one another, full service partnerships, integrated care, they seem intuitive enough, right? They seem like, why don't we just do it? And as a way of introducing our agency's role in all this work, I want to give 4 to 5 different reasons where I think something is needed. And I'll talk about it at a regional level, but even at your programmatic level, I think something that ensures more integrated services and care. Vision, levers, resources, and safe space, I think, are critical. One, I think beyond anything else, the main thing that we wanted to bring as Home for Good. Home for Good is a 5-year initiative to end chronic and veteran homelessness in Los Angeles County. It's our community's plan, all of our plan. And I think the biggest contribution that we brought is just having a goal, having a countywide goal. Beyond anything else, just the idea that we were going after something big. Because oftentimes in social services, I think we break down a really high-level goal into component pieces that we can manage, right? And that makes sense because you can't expect an employment program to have housing outcomes. You can't expect a housing authority to ensure someone's vitality and thriving. And so oftentimes we break it down and we think, and we're very good at the work that we do, but oftentimes at the end of the day, the big problem that we originally set out to accomplish still kind of persists. So, and it makes sense why. So we said it does make sense that no one can take accountability over that large goal and be held to it. So on behalf of the community, United Way, we will be held responsible and accountable for this larger goal of ending chronic and veteran homelessness. And when you have such a large goal, even for myself, when I first got approached with a job, in my mind I was like, is that really possible? And in a way, it's not possible. And that's part of the point of why we had the goal. It's not possible doing the way things were used. The way we used to do things, it's not possible to get to that goal. So having that goal forces us to change the way we do things. On the other side, I'll say it was only possible, it's only the result of having had collaborative efforts in the past that we were able to even set that goal, right? It kind of goes both ways. You set a goal, it forces more collaboration. At the same time, you can't set such an outlandish goal without existing threads and existing foundations of collaboration. So I think it goes both ways. But so I'll say one way of spotting if real integrated care and full service partnerships are ongoing at your program level in the community or anything else is there a big goal? Is there a vision that is bigger than any one group? If you see that vision, I think it's an indicator that there is collaboration going on because it's bigger than any one group can accomplish. When you actually get there and when people agree on a goal, I think the second thing you see is that when you stitch things together, when you try to put things together, things don't always fit because they weren't necessarily made to work together. So the second role that we take is really organizing and advocating on behalf of each side. I think sometimes people might feel like we're only advocating against their side, but we really take it upon ourselves to hear the voice of one group and translate it to the other group and have it go both ways. But sometimes things don't always fit when you put things together. For example, upcoming with looking at FQHCs and Medicare and seeing how those could be reimbursable and seeing Medicare as a funding stream for possibly supportive services and homeless care. The idea is good, but there's a lot of elements of that that don't fit, that would require things to have to be tweaked and changed. And we really take it upon ourselves to listen to each side and translate that story to the people who hold that in place. One practical example is, now that we're actually moving in people, we realize people need furniture. And before, there wasn't anyone doing that before. We had a lot of clothes, a lot of canned food, but we have no furniture. So there's a lot of people waiting for furniture, sitting in empty rooms. And so we take it upon ourselves, okay, moving forward, let's figure out a way to create a campaign around move-in kits or furniture to fill that missing gap. Another lever is the Funders Collaborative that Libby talked about. Providers have done an excellent job working around funders, the work we do. Providers have figured out how to layer and how to collaborate services and really make it come together. But at the end of the day, there are funding expectations that conflict with other funding expectations. So we said as funders, hey, we need to get our act together too. We need to do the same thing that providers have been doing all along and get our end in order so that providers can really collaborate in ways that they want to even more. So I think some of what that looks like is a change from outputs to outcomes. So instead of counting how many people you're touching, can we just count how many people get housed? And however you think is best to do that, feel free. We celebrate that. And as a result of that, it allows more collaborative work to take place in the meantime. Another example is subcontracting at the VA. A lot of groups do excellent work with veterans, and they do work that the VA is already doing. So we said, can you just contract providers to do that work they're already doing and get compensated for that? So that's another example. But the third thing you realize when you have come together is a lack of resources. When you're trying to do things that you've never done before together, you just need more resources. But at the same time, you have a reason to ask for resources. Early on when I was working for nonprofits, I hated asking for money. And I don't know if many of you have avoided the development department or grant writing for the same reason. But it's always nice to have a reason to ask for money. And I think when you come together with a big goal or vision, you finally have a reason to ask for money. And so we've done that with the VASH vouchers, asking the federal government, we're doing something together. Can you give us more to actually make that happen? And upcoming with the Supernova, we really pitched hard with the federal government. Can you give us our fair share, what Councilmember Perry talked about? Can you give us something that aligns much more with the problems we're facing? And now we finally have a way to exercise that, or we're doing that next step in working together. So stay tuned for what comes out of the Loss of Supernova, but we are also taking on the role of being national advocates, not for United Way, not for the Chamber of Commerce, but for LA County, for all of our work together. And now we have to figure out a way to help Peter actually process all of those vouchers. Because the other side of it, you get more resources, you need more help in actually using them. And the final thing I'll say is safe space. It's a very simple thing, but collaboration requires a place to talk about collaboration. And I think in a lot of ways, we lack for that kind of space. These kind of conferences, meeting spaces. I used to work for the mayor as a policy aide, and there was always this unspoken boundary or tension between mayor, council, city, county. We have 4 continuums of care in this county. We have multiple housing authorities. And so I think because of that, we fill a unique role as United Way of just being a neutral space, of being a safe space where people can talk honestly and openly about the challenges they face with us or with one another or with other groups, and we enjoy that role that we take. And the final thing I'll say that can't be underestimated, I think if you want to be a collaborative or facilitative body, is have people on your staff who really enjoy that. Something that I don't know if people realize, because Home for Good a lot of times takes the place of being a communicator or announcer, is I've never worked on a team with people that could care less about their reputation or getting the credit. The people I work with genuinely and honestly celebrate and want the success of others. I think as I look out onto this room, and on this panel, in the office, we talk as much or maybe even more about the good work that you guys are doing and how much we like, not even the good work, how much we like people personally. And we get excited at seeing what other people do, and I think that makes a difference in being a facilitator and in celebrating the success of other people. So I'll say at your program level in your community, because it happens in Hollywood, although we're at a regional level, it can take place in your community or in your program too, but having a bigger goal than any one group can accomplish, fixing the levers that get in the way, ensuring more resources for that big vision, and creating those safe spaces and celebrating, genuinely celebrating and being excited at the success of other people that aren't your own.
So I run the Section 8 program for the Housing Authority of the City of Los Angeles. It's the second largest one in the country. Section 8 is a rental subsidy program. It's the nation's leading low-income housing strategy. There are more than 2 million American families on this program. It is the biggest chunk of HUD's budget, and it houses more people than any other program. Public housing is a distant second with about half that many folks. It's dependent on a number of different factors. A key resource is the landlord community, because this is a rental subsidy. Folks need to rent units in the private landlord market. It also is structured in a fairly old school way. The model is you have a wait list. People get on that wait list and they wait, probably a long time, because the resource is outstripped by the size of the income eligible population by, depending on the community, probably 10 to 1, maybe something worse. So wait for a long time, get called in for an interview, get issued a voucher, go try to find housing, maybe find it, maybe not. As a housing authority, one of the key things I have to keep an eye on is the success rate of leasing for my voucher holders. And I have to overissue vouchers, because I know plenty of them are going to, not use that resource and are going to disappear. That's the traditional model of Section 8 program. Get housed, observe the conditions of your voucher, which are, maintain your lease, report in for your reexamination every year, keep the conditions of your apartment right, and get terminated from assistance if you don't do that. That's what we get paid to do. They're very tightly regulated, lot of working parts to the administration of that and the determination of income, and a lot of different pieces there that we get paid to do. What we don't get paid to do is address homelessness at all. There are some programs that do that. VASH is one of them. The Veterans Affairs Supportive Housing is an allocation of vouchers that's specifically targeting homeless veterans and in focus on chronically homeless veterans. Chronic homelessness, as you probably know, but I'll just reiterate, has a definition of time homeless, which is greater than a year or more than 4 episodes within 3 years, but it also has a disability component, so that the folks are homeless now, have been homeless for a good period of time, and also have some disabling conditions. So all of those criteria mean that the person is chronically homeless, and VASH is particularly targeting those folks. Veterans. Shelter Plus Care is another specialized program which is grant funded, requires the provision of services at an equal dollar value to the housing subsidy match. But other than a few of those programs that are targeted to the homeless, bulk of the program is not targeted to the homeless, and most agencies across the country are focused on the low income, particularly the extremely low income, 30% of area median income population. That's the funding model, the administrative funding model that we have to work with, is that. So working with the homeless and carving out pockets of our regular Section 8 vouchers to either attach to capital and services to construct long-term permanent supportive housing in project-based or sponsor-based settings, which is something that Councilmember Perry's obviously been championing for a while, and we have invested a tremendous amount of resources in, both on the Shelter Plus Care and on the regular voucher side. That's on the voucher side, that's taking an administrative decision to allocate resources from one pool to another. So right off the bat, you have to have the political will to do that. You have to have the policy authority locally, and you have to have some support to do those things, which we have obviously got certainly now. But it's, as you maybe have seen in some of the recent debates, it's a continuous challenge. Who are you serving? The question of who jumps the wait list is a real, that's a question for a lot of communities. Fortunately, it's not one that, on the city side, that's not a fight I'm fighting, but, my colleagues are fighting that fight, and that's not a small deal. So the other thing that we have to face is that the problem, as Chris and Olivia also alluded, is bigger than our resources can address. And when I talk about resource, I'm talking about a broad base of resources. It's bigger than the capital funding for the construction of new permanent supportive housing. There is not, I could put more vouchers into more projects, but there is not enough capital to support the construction of new projects. So we have to balance those resources. And then we have to compete for resources on the state level, go get tax credits to fund these things. And if we put too many things in there, we're competing against ourselves. We want to take all of them, but we won't want to compete against, cannibalize our own projects, and the balance there. So what we do then is, okay, we carve out other pockets of resources. We have had a set aside for the homeless, tenant-based regular vouchers. The criterion for admission for that is a referral through a contracted homeless services sponsoring agency, but relatively few supportive services provided to that. Some case management for the first year, housing search location, housing readiness, assistance with our process, which can be challenging for folks who are coming out of a state of homelessness. But relatively little. I have 4,000 vouchers in that program, and it's the target population is not what we're talking about here. It's for folks who are, generally speaking, housing ready. Now that doesn't mean that some providers, like we have a big partnership with DMH in that program. They target chronically homeless folks for that program because they have the commitment of provision of services long-term to keep those folks housed. But I'm not expecting that, and I don't contract with my regular providers to provide that level of care. My expectation is that this family is housing ready, and once they go off that, they come out of that program on the intake, they're out in my regular population. I don't treat, they're not with a special case manager, they don't have a special, set of practices. We do note who the contracted sponsoring agency is. We have those relationships that we can draw on when there's a crisis, and we try to do that. But there's a high degree of expectation that this family is housing self-sufficient after that. And, in my toolbox, I don't have MSW, I have very few. I have a hammer that I can threaten to use, and then I can use, and that's it. There's terminate, I can terminate I can threaten you to terminate your assistance, or I can terminate your assistance. So we need, what we need are integrated services that keep people housed. And we need to, the deeper into a service-needy population we go, we just carved out another 500 vouchers for the chronically homeless, the deeper the services we need to support them. because, we're dependent on the landlord community. If we put people out in a tenant-based environment, they're out next to ordinary folks who have to get up in the morning and go to work, and they violate their leases, we're going to push them back out into a situation of homelessness, not acceptable anywhere. Dependent on the goodwill of the community, as embodied in the landlords, we're dependent on the public support for this program and the acceptance of what we're doing. So we need to show results in terms of, street homelessness. We have to show results there, or what's the good of what we are doing? We're investing resources, didn't do anything. We need administrative resources. I get funded to take people off a wait list and terminate them when they don't. I don't get funded to run dozens and dozens of permanent supportive housing projects that each need their own monitoring. Very labor intensive there. So advocacy on that side would be critical. Metrics. I get paid to re-examine people. None of my metrics have anything to do with homelessness. What I'm paid to do has nothing to do with resolving homelessness. And HUD, it would be great if HUD could recognize efforts in that direction as something that we actually get credit for in our scoring and our valuation. And then collaboration. I mean, we need and have now extraordinary partners, both on your side and up on this side. But that's a critical resource on the relationships that we can develop in the process that we have of communicating is also really, really important to us.
I thought I'd begin by telling a story about how, for me personally, the light turned on to change in two important ways that I think is significant for how we need to think if things are going to be differently. So I started working in the homeless arena in the 80s. I worked for a community agency that was in East LA, and we got a contract with the county to do homeless outreach in MacArthur Park. And our main effort in those days was, believe it or not, linking people up to cheese, and if you remember those days. And we did what we thought was a good job, but I'm not sure how many people we actually got into housing from our program. So I went on to be the mental health director in Kern County, and then later mental health director in LA. About 2004, while I was here in LA, my wife was still working as running a homeless outreach team in Kern County. And when she was doing that, we were driving the streets of Bakersfield one day, and there are homeless people, and I found out that my wife knew by name and the story and the process for getting that individual person housed. Her team had done engagement and outreach in such a way that it was personal and connected with each person's story. And she knew, and through her team, where they were in the process of getting housed and what the next obstacle that had to be overcome was. And it was about the same time that the county went to New York to look at Beyond Shelter, and we looked at some of the efforts there. And for me, the light turned on in a couple ways. One of them was, and I've kind of distilled this to think, that when you talk about homeless people, the emphasis should be on people, not homeless. So those individuals are human beings, and you need to know the outreach team, and then later on the treatment team, needs to know them as individual humans with individual stories, and not a generic, the homeless, like on Mary Hartman, remember? So I think that is everybody would agree with that. I mean, there's nobody that would say, yes, it's a human story, but it really does take a change to move from the generic to the specific, to looking at people as individual human beings. And I think that was really the strength of Project 50 as it began. That model forced you to look at individual human beings, and then you can move out once your philosophy has changed. The second thing that everybody would agree with that was hard to really implement. So I think we have philosophies that we believe in, but we don't practically make real. So the first one is that it's the human being and the person first. The second one is you can do a lot better with a team than you can do by yourself. As a matter of fact, we found in mental health that we really could not achieve our mental health goals unless we did it in partnership. And our definition of who our important partners needed to be kept on growing and growing and growing. And so it may not be widely known, but actually the county mental health department has very strong partnerships with the city in a variety of areas, and both of us are able to do better because of that. And because I would even go beyond, Chris, what you said, it's without the big goal, we can't even achieve our little goals. I can't get a mentally ill person stabilized when they're living under a bridge and using heroin. So whatever I think I'm spending for their psychotherapy and medication is wasted until I get them housed and in substance abuse treatment. So I think those are some of the things that we've learned as we've looked and tracked outcomes of what it really takes in the real world to get individuals the help they need to thrive. So we're doing a lot of different kinds of experimenting about how that ought to happen, and I think there are a couple new venues for that experimentation that we need to think about. One of them is health reform. So whatever the Supreme Court ends up doing, I think everybody recognizes that integrated care is the only kind of care that makes sense in the long run from a clinical perspective as well as from a financial perspective. If you've got somebody with diabetes and they're drinking alcoholically, you're not going to do very much progress in containing the damage that diabetes is doing in their lives. And if you're being measured on how you do in getting better outcomes with your diabetic population, you're going to want to invest in mental health treatment that allows people to be more compliant with their medications and to reduce their substance abuse issues. You can't get in that arena either where you need to go unless you have partners. Obviously, housing is another part of that healthcare component. Somebody living on the street isn't going to be taking their insulin on the way that they need to. So that is a new arena in which our partnership needs to move forward if we're going to be successful in very large social policy matters. So we're investing right now with all of the partners that we've always worked with on trying to imagine models that would work in the future in a integrated fashion where health, mental health, substance abuse services can be delivered in an integrated way to support permanent supportive housing, for example. So our innovations grant that we have just put out is not just for our mental health team to provide support to the individuals in supported housing, but also a substance abuse specialist and health specialist to be involved also in the integrated team that supports the success of the people who are housed. It's modeled, we don't know if it's going to work, but we're going to test it, look at the outcomes, see if it works. Another thing that we're doing in partnership, we hope, with SC, but frankly we're going to do it no matter what, is experiment on using peers as care coordinators so people with the lived experience of mental illness, promotoras, substance abuse specialists as the integrating factor that creates the glue that allows the coordination between health, mental health, and substance abuse care. Because I don't know if any of you have a relative that's had complicated specialty care needed, but keeping those specialists in line with what the primary care doctor is doing is really complicated, even for those of us who consider themselves pretty sophisticated on healthcare matters. Imagine a homeless person with schizophrenia trying to do that for themselves. It just doesn't happen. And so we're trying to build models where we can use low-cost models for providing that care coordination. Another arena that we need to look at is the AB 109 population. Those individuals who are coming out of jail or prison are people who many times are at very high risk for homelessness. They have a very high percentage of substance abuse problems, but unrecognized pretty high levels of health and mental health issues as well. And so if we approach it separately, the housing component separate from the substance abuse component, from the mental health component, those individuals will be back in jail or prison. And our society will be poorer financially, as well as not being able to use productively the talents that those individuals might otherwise be able to bring to us. And so we are trying to put together those partnerships. An interesting one that we're looking at right now is to see if we can begin anti-craving medication for opiates and alcohol while the individual is still in prison or in jail, with the commitment that we'll continue that anti-craving medication either in the substance abuse system or the mental health system upon release. And if it plays out as it has in the research world, that would mean something like a 35% decrease in relapse in alcoholism and opioid use. That would be huge. I mean, 35% doesn't, from a certain perspective, doesn't sound that great unless you've worked with the population, and then you know it's really pretty good, a reduction of relapse by that amount. So I think the final thing that I'll say is that as we focus on these high-need groups that try to find them housing, if we don't also do something to dry up the springs of homelessness on the far end, we'll never make any progress, because we'll find these individuals housing, working together, we'll do that. But if there's a new cohort that exactly replaces them, we won't know that we have been successful because our streets will look the same. So we also have to look to what are the springs that drive homelessness? How can we support foster youth better as they emancipate so that they don't end up homeless? As kids get out of the juvenile justice system, how do we get them jobs so they don't get back into the same cycles that got them into trouble? We need to look, again, not just individually, but as partners at the springs as well as the current pools. So, thank you.
A couple who were homeless on the streets, and try to help them in terms of getting their life together. They lived with me and my wife after all the kids were gone for about 2 months. And it was an effort in which we found out they not only was homeless, but they had mental health problems as well. And during the time that they lived with us, we found them temporary housing away from us in an apartment which they could manage. And then coordinated for them food stuff, medication, and also weekly trips to the mental health center in which they could get help for their mental illness. At the time they moved out, and my wife always gets angry at me because I tend to bring home people that she doesn't know. And at the end of the 8 weeks that they lived with us, the wife of the couple presented us with a gift. And the gift was a samurai sword from her son, who was a captain in the military that he had picked up while he was in Japan. My wife was just appalled. That sword was in the house while we were sleeping. And those folks were mentally ill. But it was something that we experienced in trying to help people who are homeless. My wife still kind of kids me about taking in people who I don't know. I did that one person in Los Angeles when we first moved here, and she was, again, appalled. But she does work at a homeless for volunteer every week at the, it's called Many Mansions in Ventura County. So she goes there every week to work with homeless and their children. So I have some experience, some really bad experience. One day we went out, she baked a whole bunch of bread and was looking for homeless people to give the bread out to. and didn't have success. And she says, why aren't they taking the bread? And I talked to Dr. Wenzel about that, and she said, well, they have places they go for food. So we try our best, try to get involved with programs, but sometimes we succeed, sometimes we don't. Which gets to the problem of people who are homeless. They're distrusting of new relationships. They've become accustomed to the street somewhat. Now, when we talk about substance abuse, that's a different issue. We begin experiment with substances very early in life, many times before the age of 18. And when you've been using substances for a long time, it changes the way you think. It changes the way you deal with relationships, both close and those not so close. So when the issues of homelessness and family relationships become a problem with both substances, mental illness, and homelessness, the problems are complicated and very, very trying. Oftentimes in our system here in Los Angeles, we pick up a lot of people who are homeless needing substance abuse services to the emergency rooms at LACUSC in East Los Angeles. And we take them to our facility out in Acton, which is the county's facility and probably one of the safety nets that we use to provide them with shelter and also with substance abuse treatment. Recently, we took a person who had cost the county over $1 million for constant use of the emergency room as a place for shelter and for treatment over the last 3 years. Now, we're trying to document how that $1 million was accumulated because I want to present Dr. Katz savings that he's incurred because of providing a homeless person shelter and treatment so that he could get the services he needs. Yesterday I requested a beginning admission photo and a current photo, and it looks like two different people in the same world. But these kinds of changes can occur. Now, you heard Dean Flynn talk about on any given night, or I guess it was Councilman Perry, on any given night, there's around 58,000 people who are homeless in Los Angeles. Weingart Center puts the number at 82,000 on any given night. And the Los Angeles Times, in a paper yesterday talking about AB 109, said that about 52,000 people are homeless on any given night. So, given those three numbers, you can take your pick. It's either 52,000 or 81,000, but that are homeless every night here. Now, some other data that we know, 20% are physically disabled. 25% are mentally ill. Between 33 and 66% of the homeless individuals have a substance abuse problem. The largest percentage of those folks live in South and Metro LA. 50% of the homeless population are African American. 42 to 77% of the homeless people do not receive public benefits to which they are entitled. Now, we talk a lot about collaboration. And a lot of bureaucrats like myself, when we talk about collaboration, it means how much of my money can you use to provide services for the constituents that you serve. So what we have to look at in terms of the funding amounts, on how do we use dollars and resources and spending it smarter so that it includes the services and needs and addresses the needs of the individuals that we provide services to. You know, I always hear Tom Landry spoke about setting goals as an easy thing. He said it's getting to how to get to the products of that goal that's difficult to do. And that's why collaboration is essential. Dr. Southern and I always talk about things that would help people in his agency and in my agency. Now I'm beginning to find the people in my agency, 80% of them belong in his agency because they have co-occurring disorders. So, and then when we look at the homeless population, and if we say, you know, 56% of the population are homeless, 50% of the people I serve who have substance abuse disorders and co-occurring disorders belong to him. And so we work collaboratively. Now the data he talked about, the anti-craving medication, the research was done with in public health and how it works with with the population that we both serve. The great thing about some of the people that we have worked with who are homeless, they are on their third shot of the anti-craving medication, and that has changed their lives in about 90 days. 90 days. We've gotten great results in 90 days. 90% of the folks on the anti-craving medication actually complete treatment. Complete treatment. So we're getting some really, really neat things happening in the substance abuse field. The biggest problems we have in trying to turn the problems around in substance abuse is getting counselors to recommend medication as a means of treatment. So the biggest obstacle is that the medications work. The biggest obstacles is that many substance abuse counselors believe that you can't treat an addiction with another drug. And so we've got to eliminate some of those types of ideas so that evidence-based practices, which takes 20 years to come into to service, happens more frequently and more rapidly. It will actually reduce the cost of providing services to all populations. So with that, I'm going to end, and thank you very much for inviting me.
So all of the individuals that we're working with have been homeless, are at risk for homeless, and really are currently in FSPs. And I assume you all know what FSPs are because I heard you talk about them this morning. And what we're doing is we're training peers, people with lived experience, to be navigators. And so far they've been navigators to the primary and specialty healthcare systems. And I want to thank UniHealth Foundation for supporting this work, the Department of Mental Health and Marv for supporting our work, and for Pacific Clinics really being the home and the staging for all this work. And right now we're very encouraged because we did a small randomized trial of what we call the bridge intervention, and we got some very, very nice outcomes looking at health status, healthcare linkage, avoiding expensive healthcare utilization, getting people connected with outpatient care and connected with a primary care doctor or specialty care as they need it. The other thing we're doing is developing an implementation and sustainability protocol. So if there are agencies who want to adopt this intervention, we're manualizing a protocol so that they can struggle with those issues of implementation and sustainability. But what I'd like to do today is just offer a few observations from our time on the ground, specifically related to the experience of consumers. And I want to tell you 4 brief stories. When we started this work, we spent a year talking to all kinds of different stakeholders in this area of health and mental health integration. And we had a number of meetings with hospital administrators. And we were actually expecting a rather warm reception. And as Marv alluded to, Dr. Southard alluded to this morning, well, I don't want to characterize it as not warm, but I will say that what they suggested to us is if we wanted to think about getting health care, primary health care services for the seriously mentally ill living in the community, they advised us to go to Skid Row. And I didn't want to get into any arguments with them, pointing out that while some of our folks have in fact been homeless and probably will be in the future, they don't choose to get their health care in Skid Row. And actually not all homeless people live in Skid Row, and certainly not all people with serious mental illness live in Skid Row. So avoiding that argument, we thanked them and decided we have a lot of struggle ahead. And we began to see this issue of stigma as really rather dramatic. So I want to give you 3 stories of consumers that we've learned some lessons from in terms of healthcare integration from their perspective. The first was a fellow who had a very severe lesion on his foot, and he had been going to the emergency room repeatedly for care. And in fact, he did get care at the emergency room. The problem is that he never engaged in any follow-up care. Now, he was a member of an FSP, and every time his lesion erupted, they would tell him to go get care, and he would. He'd go to the emergency room. Never involved in any follow-up care. So by the time we engaged him, the next plan was to amputate his foot. This guy was about 45 years old. We got him engaged in our health navigation plan and our health navigator intervention, and fundamentally the issue was, obviously he was using very intensive services inappropriately. He could have been cared for as an outpatient, but he waited a very long time, went to the emergency room, they gave him treatment, they reduced the infection, shot him up with penicillin or whatever they needed to, sent him out, and at that point he stopped taking care of himself. So our plan was help him care for himself, learn how to care for himself, and still has his foot, thank goodness, is engaged with a primary care provider and has learned to self-manage his own medical care. What we learned is that even when comprehensive health services are used, they're a failure without adequate follow-up care. And this follow-up care is not a given with our population. A second woman was complaining of tightness in her chest, difficulty breathing. All of us in mental health know that those are classic signs of anxiety. So she was treated very well for anxiety. Didn't seem to do the trick, though, in terms of her chest tightness and her shortness of breath. So when she was engaged in health navigation, we, of course, connected her and got her involved in her own care and got her connected with a primary care physician. Unfortunately, what they found was a very large tumor in her chest. Now, the good outcome of this was that even though she did die, she died with good hospice care. I'm sorry, I didn't mean to put it that way. The only good outcome here was that she didn't die alone. She died in hospice care that we were able to connect her with so that she didn't die alone in an SRO. She didn't die alone on the streets. She was given good hospice care because the tumor had grown to the point where it was no longer treatable. And I'd like to end with a slightly better story, however, of a woman who had not had any primary care for over 10 years, and this is not uncommon with our population. Many of them have given up getting health care. And so a woman did, in fact, have a lump in her breast and decided she didn't want care. She'd been to the healthcare system. She decided it was too much trouble, there was too much stigma, it was too complicated, and she really was just going to live with whatever the outcome was. In fact, she'd had a substance abuse problem and had had some success with her substance abuse problem, and she said, you know, I've done a lot. I've recovered from a lot. I'm willing to live with whatever happens to me. So through our process of engagement and getting her involved, we did get her to a primary care doc, and we were able to get her to specialty care at City of Hope, where, in fact, she was in a very early stage of breast cancer and is now receiving successful treatment. Now, we've learned from these folks that, and we live with this daily, that these individuals do die 25 years earlier than the rest of us. And they die due to preventable health conditions. And we have learned that we have to keep getting better than this, and we've learned that there's a problem at every single stage, from consumer awareness to assessment to the office visit to the exam room experience to follow-up. There are challenges everywhere in that process. So we're very encouraged by this attempt at using peers to become trained health navigators to link mental health services and primary care services at the level of the consumer. To finish, I just want to offer a few brief observations as well. Some of the things that we've learned, and this is not news to anyone in this room. If you include substance abuse services, we have this kind of perfect storm of trifurcation in terms of problems with financing, policy, funding streams, training, scope of practice. It's really a perfect storm for preventing integration of these services. A second observation is that stigma is extraordinary, particularly for people with serious mental illness. We have encountered stigma everywhere we have gone. And that includes times where we are dealing with mental health providers who say, you know what, you're really not going to be able to get this person to manage their own care. Now, we're dealing with everyone who's well-intentioned, and we are dealing with people who want the best outcomes always. But as was alluded to in the earlier panel, we're dealing with practitioners who sometimes build up ideologies through experience and sometimes through other issues where they lose their own sense that someone can make change. And our intervention is really based on a self-management approach where we train people and teach them to take over their own health care and self-management to the greatest degree possible. So we have found that this self-management approach is critical so that consumers can become skilled and empowered to navigate through these care systems and to become as proactive as possible in their own care. Because we obviously want to be thinking at the level of systems and all of that integration that's required. We also have to engage consumers in their own care, in their own sense of self-management, so that they can become active in their own care plans. And that's how we've done it in the bridge intervention. And the method we use is something we call for them, with them, by them, where we do what we call modeling, coaching, and fading. Those are all the behavioral terms. For the peers, we call it for them, with them, by them, and they get it immediately. The first time you do it for them, the second time you do it with them, the third time they do it. And that goes from everything from making an appointment to getting to the doctor to doing follow-up care. So that's our bridge intervention that we've been very excited about and have gotten some nice findings on. And I just wanted to end with a couple of core issues that we've all actually been talking about today. Sometimes when I present this idea of health navigation and peer health navigation, people will look at me and say, oh, I know, we need to get a van. And yeah, that's right, transportation is a big issue, but that's actually, in some ways, the least problematic issue that our consumers face. Just getting them to the right door is absolutely not enough, because we have seen the problems before the door, after the door, and once they walk back out in terms of managing healthcare issues. And the other issue is the notion that we just need everything under one roof and our problems of integration will disappear. And I think the issue there is that, Lord, are we ever going to have enough roofs? As well as even under one roof, we still have problems of financing, training, scope of practice, and stigma that can remain. So we're probably going to need, as the panel earlier today so nicely said, many models and/or components, many models of integration across these systems of health, mental health, and substance abuse, and many different components of integration, such as peer navigation, or other models that were talked about earlier today. The only other thing, as we all know here, is that these problems are so critical to solve, and it is extremely rewarding to do it. We do biweekly supervision with our peer navigators that we have trained, and with the support of the Department of Mental Health, we're training more and more. And every week we start our supervision off with successes and challenges. And the successes are remarkable in terms of how people's lives, we all know that health and mental health intersect. Not just we want them to intersect as systems, but they interact in our lives. And to watch people get good integrated care and the impact that has on their lives and their mental health is extraordinary. And it's actually been, frankly, the most rewarding work that I've done in 30 years in the field of mental health. So it's very personally gratifying. Obviously, it's a huge humanitarian charge, and it's just wonderful to see this room as full of people as we have today talking about these amazing issues. So
I want to talk a little bit about healthcare reform and the opportunities and challenges that this brings to us here in Southern California, as well as some of the issues that I think that it presents for us, particularly many of you who are on the front lines. Can you hear me okay? Okay. First of all, Suzanne Esta talks a little bit about the science of integration, and the science of integration isn't real good. I think if you listen to John's data and some of the other projects that are being developed around the country, we're beginning to move the needle a little bit in understanding what we need to do to bring together different kinds of provider organizations, but also different scope of services, not only just health and mental health, but as you mentioned, substance abuse, family services, housing, and many other things, even education. And So I think as health reform sort of unfolds, it's going to create us new opportunities, not just to experiment with projects like John was talking about, but also to come up with new ways of measuring the outcomes as well as the process indicators that can help determine what is successful and what's not. So that's going to be very important to do, so we know what works and what doesn't. Basically, the science of integration, as I said, isn't really well developed, but we do know that simple things like putting people into supportive housing can reduce unnecessary trips to the hospital emergency department. It can improve health status and improve compliance. And so there's some basic things that we can do really right now to move people into a supportive housing situation. And of course, the problem there is, do we have the resources to build housing and to link people once you put them into housing with the resources that are needed? So what are the opportunities under healthcare reform to do that? Well, first of all, to say that, Don Burrick, who's a recent head of CMS who just left, said that he's really looking towards a healthcare system in the United States that's built on what he's called the triple aim of improving the experiences of patients, improving the health of the population, which is something we don't do too much. We think about individual patients, and reducing overall healthcare costs on a per capita basis. And he actually argues, and it's interesting that he said, John said, do we have enough roofs? He actually argues that one of the successes really accomplished this triple aim is to have what he called an integrated organization, to have somebody, an organization or an individual or a policy level set of agencies that really have the accountability, the responsibility and accountability to really integrate services. And I was really struck today by listening to all the people from the county and the various agencies is that, we've really compartmentalized this system. We got housing and we got substance abuse and mental health, and everybody works out of different organizations with different budgets, and so there's not a lot of ways for a nexus of integration to occur at a policy level. And I think Berwick is trying to get to the point where we really need to get to a point where somebody has to develop some level of accountability and responsibility in order to really drive the integration. And I think if we do that, I think we'll begin to see some more successes along the lines of what John and others are beginning to study. Now, there are some really important opportunities under healthcare reform. Now this is assuming that Supreme Court upholds the law when the decision comes out in June. But one of them is the expansion of Medicaid. If you go to the state of Massachusetts, 95% of all homeless people are covered by Medicaid. In California, it's about 20%. And all of you know how difficult it is to move people through this enormously complicated system of identifying their eligibility, particularly as a disabled individual, and moving them into the Medicaid program. Well, under healthcare reform, hopefully all of that will go away, where essentially anybody who is under a certain poverty level, but basically 135% of poverty, unless you're an undocumented immigrant, will become eligible for Medicaid. Now, the problem with this issue is this is one of the 4 issues that the Supreme Court is debating. Many of the states have challenged the law, the constitutionality of the law that requires the states to, after about 5 years, to cover half the cost of this. So who knows how this is going to pan out in a couple months when the court rules on this. But the opportunities to significantly expand people into the Medicaid program is that it provides the opportunity for services not only to the individuals, but also it allows us to connect individuals to broader systems of care, including housing. And we know there are several service-based housing programs, supportive housing programs that have been linked, some of which are services are paid for in part by Medicaid through the cost-based reimbursement program called the Federally Qualified Health Centers. So this is an enormous opportunity, if in fact we can sustain this, to move people into Medicaid and then build on those concepts and ideas for developing navigator systems that John was talking about, for service-enriched housing programs. But this is going to be a big if, assuming we can get this law sustained, and also we can move people into into Medicaid, which is not a big problem. We have to find people, we have to determine their eligibility and enroll them. Second thing I want to talk about is the concept of the patient-centered medical home. And, you know, we're really intrigued by this, and it really sounds really cool to hook people up to medical homes. And, you know, a lot of people don't really understand all of what's involved in this concept of the medical home, or what it's going to take to really transform our primary healthcare delivery system to be more aligned with this concept of a patient-centered medical home. Well, what are these? What are some of these things? And I wanted to stop with there. We wanted to hear other people talk. One of them is the concept of the patient-centered medical home. Is the notion of what does it mean to be patient-centered? It sounds really neat, patient-centered, but what does that actually mean? And essentially, in the theoretical sense, it says, you know, what we need to do is change the delivery system so it's really based around the needs of the patient and not the provider. And if you go to any of our community-based provider organizations, or even high Medi-Cal providing Medi-Cal provider organizations, a lot of the services are built around the needs of the organization. And so transforming that for a clinic, for a doctor, for a nurse practitioner, to really build the concept of how they deliver care, how they organize their care delivery to be more responsive to the needs of the population is a big challenge for everybody. For this population, it's particularly difficult, and it's going to be a big challenge for the organizations. Second of all is the notion of establishing an individual physician or a clinician as a sole provider. You know, many of our homeless providers or homeless service providers are not organized that way. They're organized essentially in an episodic fashion. Our county healthcare system is also organized that way. We're trying to move it, transform it a little bit. But where we identify that an individual has one doctor or a nurse practitioner that he or she calls his own or her own. Okay, that's a major part of the change towards a patient-centered medical home, and that's going to require a significant transformation in the way we organize and deliver services. And how we do that for homeless individuals and vulnerable populations is really unknown. And I think John's idea is that having these navigators has a lot of value, because I think it's one way we can actually begin to connect people to an organization. It doesn't necessarily have to be a physician or a nurse practitioner, but a person that a homeless individual can relate to on an individual basis. The third thing is obviously the integration and coordination of care. Where you going to, so we've been talking about that all day, but what's different here in terms of healthcare reform is that we want to begin to hold the provider, an individual provider, accountable for that integration. Not that we think it's going to happen by itself or because we think it's going to be important to do, but we're going to actually hold a provider organization or an individual doctor financially accountable for that level of care and that coordination to occur. And fourth is the concept of a team-based approach. It's interesting. I ran healthcare for the homeless clinics many years ago when we started clinics all over the country in 23 different cities, in Boston and Atlanta, New York, and everything. And we developed the concept of a team approach. And this is the 1980s. Now all of a sudden it's really innovative. Oh yeah, we've got to move patients to a medical home. We've got to have a team approach to healthcare. Well, healthcare for the homeless providers have been doing this since 1985. We know how to do it. Many of you know how to do it. But what's key is that we begin to institutionalize and formalize this so it begins to make sense on a broader basis, and also to bring in new types of providers like navigators, case managers, who can help connect the dots for all these organizations. Finally, a focus on quality and not just access. We haven't talked too much about the quality of care, but for the provider, for an integrated delivery system to work, we also have to look at this question of quality. Are people achieving satisfaction with the care that they're getting? Are people and homeless people getting into housing? Are they staying into housing? Are they beginning to get their health and their mental health status under control? Are they becoming more functional? So I think the focus on the medical home really also has to transform to this question of quality. And I think when we look at transforming our own delivery system here in Southern California, we need to add that dimension as well. So to close, I'd say, all these things pose tremendous challenges to all of us. Tremendous opportunities with healthcare reform, with new resources, a new commitment to this. It's going to take a lot of advocacy. It's going to take some research in terms of understanding what works and what doesn't, new ways of measuring some of these outcomes. And I think an approach that is going to require a lot of creativity, innovation, and a real cross-disciplinary way to engage this population and see if we can really make a difference.
I've been asked to speak a little bit about the organizational context of services integration, and I thought I'd begin by telling you a little bit about the work that I do. Dean Flynn mentioned earlier this morning that it takes an average of about 15 to 20 years to translate research into routine practice. And I've been very curious about that, why it takes so long, you know, what are the barriers to translation, what could be done if something should be done to sort of reduce that amount of time. So I've been spending a lot of time looking at different types of organizations and how they operate in terms of providing quality services to their patients, clients, consumers, whatever you want to call them. And two contexts that I'm currently doing work that relate to the issue of services integration. One involves looking at integration of services for children who are or adolescents who are involved in child welfare systems. And this particular project is looking at a particular evidence-based practice known as multidimensional treatment and foster care. And it's really intended to provide comprehensive behavioral health services to at-risk youth who are in foster care placements. But it involves a collaboration between county child welfare programs in California and Ohio, county mental health departments, and juvenile justice systems. So I've been looking at what makes for a successful collaboration and the scaling up of this particular evidence-based practice for this particular population. Another study that I've been involved with is actually under the direction of Todd Gilmer, who's at the University of California, San Diego. And it's looking at the fidelity of another now evidence-based practice, the Housing First model, in full-service partnerships here in California. And so that project as well is looking at the integration of services more specifically and more related to why we're here today, to the issue of housing for the homeless, for older adults, severely mentally impaired, and so forth. And what I've learned from those two activities or those two projects, I'm going to summarize in terms of three things among many things that I've learned. But the first lesson that I've learned from that experience, I think, was best summarized by a statement issued by a candidate for the office of President of the United States, who said a couple of months ago, "Corporations are people too, my friend." I'm sure you probably caught that on the news at some point, although I'd like to say that it's not corporations so much that we're concerned with, but agencies. And the reason why I say there might be an element of truth to that statement has nothing to do with tax breaks, but has more to do with the fact that integrated services delivery is ultimately based on relationships. And this was a comment that Marv Southern made in the panel this morning, that relationships are critical to services integration, because integration involves individuals who represent different specialties, different agencies, different systems of care, and in fact, different organizational cultures. And the success or failure of systems integration really depends on the quality of these relationships. So based on the fact that relationships are key, the second lesson that I've learned about systems integration is that successful integration requires three specific elements to these kinds of relationships. The first is communication. Now, that means you not only have to have a willingness to communicate with the other people involved in providing services, but you also have to have an ability to speak a common language. Now, you would think, well, that's a no-brainer. We're all speaking the common language. But even in the panel this morning, I could detect subtle linguistic differences in the terms being used to refer to the same group of individuals and the same approach to delivering services that suggests that even though we may go to the same classes in college or graduate school, even though we may work with one another day to day, we're each equipped with a different set of terminology, languages, that we employ in our day-to-day work with the people that we serve. So having a common language is important. Secondly, the ability to collaborate with one another. Now, that was a constant theme in this morning's panel about the importance of collaboration. And one of the things that I've learned about collaboration is that there are three components to it. One is what a lot of health services researchers refer to as the outer context. And by that they mean, you know, is there a demand for collaboration? Is somebody telling you, you folks have to work together? Are there resources to do it? In this case being, do you have candidates or recent graduates from places like schools of social work who know how to work in other systems of care, who can both do mental health and substance abuse and physical health and work in those environments simultaneously? Is there money to support something like this? Mandates is another element. When the law tells you you have to provide integrative services, that's an illustration, or the Healthcare Affordability Act now mandating services integration, is an illustration of that outer context. Another component is the inner context, and by that I mean, do you have leaders like the head of Substance Abuse Prevention and Control, or DMH or DHS, who really believe in integration, who, you know, preach it every day in every way, not only to one another but to their staff, and their staff get it. So having a supportive leadership, having an interorganizational culture that not only takes care of the same clients, but basically shares the knowledge, the attitudes, the behaviors that really constitute what a culture is all about and what brings people together and gives them the marching orders to do what they need to do to provide effective quality care. Another element is having an influence network. Much of the research that I've been doing has shown that systems leaders who can tap into people that they know who are doing similar things, who can advise them on whether they should adopt new programs and how they should do it, are much more likely to move further along than systems leaders who don't have that. And the fact is, we're not all equally endowed with the same kinds of influence networks. And then there's the element of the format. How often do people from different systems of care get together to talk about these issues? Do they meet on the fly over lunch, or do they meet once a month, or is everything conducted by email? These are all elements that have a major role to play in the challenge of actually working together effectively. So communication, collaboration. The third C that's especially critical is the willingness to compromise. The fact is, we're all trained to know that there's a right way and a wrong way of delivering services. And then when we begin to interact with people who have a different vision of a right way and a wrong way, well, whose way dominates in that situation? We have to exhibit a willingness to negotiate and perhaps not get everything that we'd like to get because we've been trained to believe it's in the best interest of our client, but through that collaboration begin to develop a new way of delivering services. And that's the third lesson that I've learned, and that is that successful collaborations involve some form of what I call a cultural exchange. And by that I mean that you not only exchange knowledge about how to serve these clients, but you, in this case the homeless, but you begin to transform your own systems of care, begin to exchange ideas about what you do know and what's appropriate, your attitudes towards services delivery, and your ability to provide services in collaboration with one another. Now, of course, that requires a supportive leadership. It requires a supportive or favorable outer and inner context. It may also involve a culture broker, somebody who knows how to translate and facilitate that exchange between mental health, substance abuse, and physical health in the context of delivering services to the homeless. So I'd like to summarize with two conclusions, or two pieces of advice. The first being that healthcare reform has taken us all on a new path towards systems integration. Now, of course, depending upon what the Supreme Court does in June, there may be a major roadblock in that path, but nevertheless, as you know, systems like here in LA County have already made that decision. And as they say, as John likes to say, that train has already left the station. But nevertheless, the physical health, mental health, substance abuse treatment represents not just different systems of care, but different cultures and traditions. And the key to successful integration of these cultures and traditions essentially lies in creating a new culture, a culture of integrated services delivery. So as you move forward, you know, I'd certainly encourage more dialogue. You know, this conference today is perhaps a first step along a step of not necessarily more conferences, but certainly more dialogue about the problems that we face and the solutions to those problems. More collaboration to identify common resources, unique resources, as well as collaboration to overcome the barriers. And even though compromise has become a dirty word, at least in the political context these days, perhaps a little bit more compromise is something that I might also recommend.